All right, Brendan and I have spinal cord. Joke time just to ease the tension of the day. How does a spinal cord hammer a nail into the wall? Hmm. Spinal tap. All right, the curves that we all deserve. There's two types of curves in the spine. We have kyphosis and lordosis. Kyphosis occurs in the thoracic spine, and this is the primary curve that's developed at birth, and it makes room for our abdominal and chest cavities. Our lordosis occurs at the lumbar and the cervical spine. It is known as the secondary curve, which develops after birth. The lumbar lordosis helps us to sit upright, and the cervical develops as we begin to gain the ability to look around. Now, these are some of the curves that will give us some problems in life. We have scoliosis, which would be this top left right here. Excessive kyphosis, which will be this top right. And as you can see, there's an excessive curve in that thoracic spine. And then we have excessive lordosis right here. And as you can see, it's pushing into that anterior pelvic tilt. Next, we have our enlargement compartments. The first one we have is the cervical enlargement. This is an enlargement that extends from C4 all the way into T1. And then most of the anterior rami of the spinal nerves from this enlargement join together to form the brachial plexus, which also innervates our upper limbs. The next enlargement we have is the lumbar enlargement. This extends from L1 all the way down to S3, and the anterior rami of this enlargement join together to form the lumbar and sacral plexus, which is known to innervate our lower limbs. And this is just an actual picture of a cadaver. And as you can see, this is our cervical enlargement. It's in our cervical spine, and it starts around C4, and it's going to go all the way down to about T1. And here is our lumbosacral enlargement. Now we're going to get into our spinal meninges. These consist of the dura mater, arachnoid mater, and the pia mater. And these are just their primary function is to protect the spinal cord, and I'll get into what each one does next. Our dura mater, this is the most superficial layer. It's a tough, thick outer covering. It also covers the brain. This layer is richly innervated by sensory nerve endings. The middle layer is known as the arachnoid mater. This layer is not innervated. And the deepest layer of them all is known as the pia mater. And this directly covers the brain and the spinal cord. Now we're going to get into some few structures that we expect to find. We start with the conus medullaris. Now, as the spinal cord ends around the L1, L2 vertebrae, its tapering end is known as the conus medullaris, and that can extend as low as L3. The function of the conus medullaris is to stabilize the spinal cord by connecting the end of the spinal cord to the coccyx, and this is done by the coccygeal ligament. Then we get into the quada equina. This is considered a bundle of nerves coming from the lumbosacral enlargement. These nerves include lumbar spinal nerves, sacral nerve pairs, and also the coccygeal nerves, which are all responsible for motor and sensory innervation to the legs, bladder, anus, and also the perineum. Next, we have the filum terminale. This is known as an extension of pia mater attached to the coccygeal leg segments. The function of the filum terminale is to suspend the spinal cord and cerebral spinal fluid. And this is just a picture of a cadaver where we can actually see where each of these structures are at. And as we can see, the conus Medullaris is at the end, around L2. And we can see the quadra equina and also the phylum Terminale.
So I'll be getting into talking about some of the roots and rootlets that we expect to find once we do our dissection in a few weeks. So start off in the dorsal. The dorsal roots and rootlets are meant to carry afferent sensory information to the spinal cord. So the order of progression, it'll be from skeletal muscle, it will eventually travel into the spinal nerve, then to the dorsal root ganglion, the dorsal root, the dorsal rootlets, and finally it'll synapse in the dorsal horn of the spinal column. Ventral will carry efferent motor information from the spinal cord. It'll go from the ventral horn of the spinal cord to the ventral rootlets to the ventral root, where eventually will synapse with the dorsal root and form the spinal nerve. Christian actually volunteered to pause and talk about the medial lemniscus pathway. Ligaments. So there's quite a few ligaments kind of around the spinal cord and to the vertebral column. The denticulate ligament, the ALL, the PLL, and the ligamentum flavum are some of the more important ones that we'll get into right now. The denticulate ligament looks like a thin sheath that travels all along the spinal cord, but it's actually going to be 21 pairs of denticulate ligaments going down. And its primary purpose is to anchor the spinal cord. The supraspinous ligament will travel from spinous process to spinous process, starting from C7 going down to L4. Above C7, it's actually going to be the neutral ligament, which you can see in this picture on the right. And its primary purpose is going to be to resist excessive flexion. We'll see if we're able to save this when we do our dissection, at least on a few bodies. It'd be cool to see, but I imagine it's going to be pretty tricky to not cut through this one. And then the anterior longitudinal ligament and the posterior longitudinal ligament location. The ALL will extend from the anterior aspect of the vertebrae, from the pelvis up to the occipital bone, and it's going to prevent excessive extension. The posterior longitudinal ligament is going to extend from the posterior aspect of the vertebrae and prevent excessive flexion. Kind of like the supraspinous ligament, we'll see if we're able to preserve this in any of our bodies during the dissection. As for vasculature, there's going to be one anterior spinal artery. There's going to be two posterior spinal arteries. The anterior is going to travel along the anterior portion of the spinal cord through the anterior median fissure, while the posterior is going to emerge from the vertebral artery or the posterior inferior cerebellar artery. Spinal cord's a pretty big deal for the PTs, obviously. Dermatomes, myotomes, radiculopathies, reflexes, spinal cord injury. It's the basis for movement. Obviously, this is kind of what we do. So an injury or a compression, anything like that can really disrupt movement and cause pain. It's a big basis of what we do. And as we learned in neuro a few weeks ago, obviously we can use something like a spastic or tonic muscle and use that to help you. This would be similar to the task-oriented theory. As one of the examples Dr. E uses is her patient that used their spasticity to get up from a wheelchair. We haven't done our dissection yet. We actually don't even present until next semester. But when we do the dissection, some of the problems that we expect to encounter is performing the laminectomy of the vertebrae. We're going to be using a lot of tools. It's going to be tough to cut through. It's going to be tough to not cut through some of the structure of the spinal cord that we want to preserve and teach. We're going to have to probably get through a lot of musculature and vasculature out of the way before we can even do the laminectomy. And we also have to get there. It's been a tough semester, so we'll see if me and Corey are still standing by the time we get there. Key teaching points that we want to make to the first years. First of all, we want them to be able to identify the important structure of the spinal cord, such as the cervical and lumbar enlargement, the dura, arachnoid, and pia mater, the phylum terminale, conus medullaris, all the ligaments and vasculature that we hope to preserve. Secondly, we want to have the first years be able to have a base understanding of how sensory and motor information is carried in the dorsal and ventral columns. Obviously, that's not something they'll get into too much until the summer for their neuro, but I thought that having a couple of current third years teach us this during lab last year was pretty helpful when it came time. And thirdly, we really want to build their understanding of what signs and symptoms could possibly be present from an injury of a specific spinal cord levels. That's all we have. Thank you guys so much for listening. Let us know if you have any questions.